everyone, so I'll be talking about mechanical ventilation. In this video, I shall focus on invasive mechanical ventilation. I'll try to cover certain concepts in mechanical ventilation, the ventilator settings in ARDS and COPD specifically, a little about weaning off of the ventilator, and finally about the role of PEEP in congestive heart failure. So, what is invasive mechanical ventilation? This is the delivery of positive pressure to the lungs. It is done using the endotracheal tube or the tracheostomy tube. If it's a non-invasive ventilation, we use a face mask. Now, when do we use mechanical ventilation? The indications are first respiratory failure. So basically, mechanical ventilation tries to replace the patient's work of breathing and facilitate gas exchange. And it is also used in patients with depressed consciousness or altered mental status. So for example, if the glaucoma score is less than 8, you have to intubate, which is a kind of invasive mechanical ventilation, because in these patients, their airway cannot be protected because they aren't conscious. Now coming to the modes of ventilation, the first mode that I'll be discussing is volume limited mode of ventilation. In this type, the tidal volume or TV is going to be set. Under volume limited ventilation, you have three types. The first is CMV or controlled mechanical ventilation. Here you will have a set tidal volume and a set number of breaths, that is a set respiratory rate. In this case, the patient does not initiate any ventilation. There is no patient-triggered ventilation. So this is mainly because mostly the patients given CMV are either sedated or in coma. So they can't really initiate their own ventilation. So that's the first type. The second type is AC or assist control. Here also we set the tidal volume because it's volume limited, and we set the respiratory rate. So the minimum number of breaths is fixed, which means that the respiratory rate can never go below that number of breaths. However, in assist control, the patient can initiate extra ventilation above the set limit, and each time the patient initiates an extra ventilation, each of those times he will get a set tidal volume. So in AC, the patient initiates breaths on his own. So for example, if the respiratory rate is fixed at 10 breaths per minute by the ventilator will give the 10 breaths, but the patient can increase the number of breaths per minute to say 15, meaning the patient will add 5 extra breaths above that 10 breaths that is set. But the ventilator will prevent the number of breaths from ever dropping below that limit, which is 10 breaths per minute. So the patient can definitely breathe for more than 10 breaths per minute, but can never go below 10 breaths. So the limit is set at 10 breaths per minute. And for each patient initiated breath, as I've mentioned, the tidal volume that he gets will be set. The next type is IMV, that is intermittent mandatory ventilation. This is the same as assist control, but what happens is each time the patient initiates a breath, he will not be given a set tidal volume. The patient can increase the number of breaths by spontaneous breathing. It will not be a patient-initiated ventilator breath. It will just be spontaneous breathing. So the patient increases the number of breaths by himself, but unlike AC, each patient-initiated breath will be how much ever that patient can take in. So for example, if the minimum limit is 10 breaths per minute, the patient takes an extra 5 breaths, then in each of those extra 5 breaths, the volume will be whatever that patient can take, and it will not be the set tidal volume. Alright, so these are the three types of volume limited mode of ventilation. The second type is pressure limited ventilation. In pressure limited ventilation, the inspiratory pressure is set, so the tidal volume will vary. In this case, we have something called the peak airway pressure, which is basically the inspiratory pressure plus the PEEP, which is the pressure that is within the alveoli. So inspiratory pressure plus PEEP is peak airway pressure. And here, since we are setting the pressure, the inspiratory pressure and the PEEP are kept constant and set, so the peak airway pressure is also constant. And in pressure limited ventilation also you have three types, that is CMV, AC and IMV. Now, in this pressure limited, a few points I would like to add is that since inspiratory pressure is set, the tidal volume will vary with the lung compliance and the airway resistance. So you know that compliance is equal to the change in volume by the change in pressure. Since we keep the pressure set, the volume changes with the change in compliance. So for example, if the lung compliance is high, then you will have a higher tidal volume that is provided for the same amount of pressure. Alright, now the next type is pressure support. Pressure support is when a set pressure is delivered during inhalation, but the difference here is that every breath here must be triggered by the patient. You will not set a number of breaths to be given by the ventilator because the patient triggers the number of breaths. So now, as you can imagine, the pressure support has some disadvantages because each breath has to be triggered by the patient. It cannot be used in patients with a depressed respiratory drive. And since we don't set the respiratory rate and we don't set the tidal volume, there is really no guarantee that sufficient minute ventilation will occur. Because if you remember, minute ventilation is the tidal volume into respiratory rate. Also, pressure support cannot be used to provide a full ventilatory support for the patient. And usually we use a pressure support along with the IMV type of ventilation. Alright. Now before we move on to settings, I would like to mention that there are a few factors that would influence the mode of ventilation that we choose. For example, the mode that we usually use in an ICU is volume or pressure limited, and usually it would be in the AC mode. This is because the ventilator provides the most support to breathing in this mode, and it allows also the patient to trigger breaths above the set limit. So this is essentially reducing the risk of atrophy of respiratory muscles. And for patients with respiratory failure, they require more ventilator support than in those patients whom mechanical ventilation is done just to protect the airway. Also, the indication for the mechanical ventilation also helps decide the type of mode. Like for example, for patients with COPD or an asthma exacerbation where airflow limitation is the main cause, we generally go for a volume limited AC mode, which is preferred over a pressure limited or pressure support mode. Now usually suppose we see a patient where we want to limit the pressure in the lung, like we don't want the pressure in the lung to go up a lot, like for example when there is air leakage as a pneumothorax. In these cases, we use a pressure-limited AC mode to reduce the risk of barotrauma. Another example would be if there is a raised intracranial pressure. In these cases, if you have a very high intrathoracic pressure, that essentially reduces the venous return from the brain, and you don't want that. So here we use a pressure-limited mode where we will set the ventilator at a low pressure so that we know that the pressure is not going to go too high. Alright. Next, coming to the settings. So these are common values that we generally set in the ventilator. For example, tidal volume is usually set at 6 to 8 milliliter per kg, and 4 to 8, that is a low tidal volume, is set for those with ARDS. We usually try to avoid a very high tidal volume because that can be associated with barotrauma and lung injury. The respiratory rate is usually set at around 12 to 16 breaths per minute, but for ARDS you need a higher respiratory rate. That is because in ARDS we are giving a low tidal volume, and to maintain the minute ventilation we have to give a higher respiratory rate. Coming to PEEP, the PEEP is usually kept at 5 centimeters of water, and we generally go for an optimal PEEP, not necessarily a very high PEEP, but an optimal PEEP in case of ARDS. And that is because in ARDS we are trying to prevent alveolar collapse, because PEEP essentially provides a positive distending pressure. But it's important that a very high PEEP in non-ARDS patients can lead to increased intrathoracic pressure. Elevated intrathoracic pressure reduces venous return, that reduces cardiac output, essentially leading to hypotension. This, in fact, would be helpful in cases of congestive heart failure, about which I will be talking in the end of this video. A high PEEP can also increase the intrathoracic pressure and reduce cerebral venous return, therefore increasing the intracranial pressure. So these are certain points that you have to keep in mind while setting PEEP in a ventilator. Next is the FiO2. The goal of the fractional inspiration of oxygen is to keep the SpO2 at around 90 to 96%. Some adverse effects of a high FiO2 is something called absorption atelectasis. And also in patients with COPD, if you give too much oxygen, there is a risk of worsening hypercapnia. So that is why in patients with COPD, the FiO2 is kept at a lower limit of around to reach a PA, a partial pressure of oxygen of 55 millimeter of mercury, and the SpO2 of around 88 to 92%, and that is to prevent an exacerbation of hypercapnia. Alright, next is inspiratory flow. We keep inspiratory flow at around 40 to 60 liters per minute. And you have something called the inspiratory to expiratory ratio, which is essentially the time that is taken in inspiration is to the time in expiration, which is maintained at 1:2 or 1:3. Here I would like to point out a concept. So in case of COPD, there is essentially airflow limitation. So that the patients with COPD have difficulty in exhaling air. The time taken to exhale is actually more. So in these patients, what we prefer to do is we increase the inspiratory flow rate. So if the rate is increased, the time spent in inspiration is decreased. So the time that could be spent in expiration in the total time can be increased, thereby giving them more time to exhale all that air. Alright, and there are other two important things to note. What are the two factors that change partial pressure of carbon dioxide? That is the tidal volume and the respiratory rate. Increasing the tidal volume and increasing the respiratory rate causes a decrease in the partial pressure of carbon dioxide. Whereas changes in the partial pressure of oxygen is determined by PEEP and FiO2. Increasing the PEEP and increasing FiO2 can lead to increase in PO2. Next, coming to certain important terms that are used to measure pressures in mechanical ventilation. Starting with the peak pressure. Peak pressure is the pressure that is measured as we are delivering the tidal volume. So it is essentially the airway pressure. You can think of it as a formula. Peak pressure is equal to the resistive pressure, which is the pressure in the airways, plus the plateau pressure, about which I'll be talking about in a second. And this resistive pressure in the airway can further be formulated as airway resistance into the airflow. So this is the peak pressure, essentially the pressure that is measured as we are delivering the tidal volume. Coming to plateau pressure is what is measured during an inspiratory hold. Now what happens in an inspiratory hold is that there is no airflow when you're holding your breath. So the airway resistance is essentially zero. So if airway resistance is zero, the resistive pressure in the airway is zero. At that point, the pressure that you measure is the plateau pressure. The plateau pressure is the elastic pressure plus the PEEP. The elastic pressure means it's an intrinsic characteristic of the alveoli which is directly proportional to the elastance and inversely proportional to the compliance. Alright, so plateau pressure is the elastic pressure plus the PEEP, and it reflects the lung compliance. So what happens is that if the elastic pressure is high, it basically means that the compliance of that alveoli is low, which means that the plateau pressure is high. Now, what are the factors that change these pressures? So you have two important concepts. The first is if you have an elevated peak pressure with a normal plateau pressure, please note that peak pressure is the plateau pressure plus the resistive pressure in the airways. So you have an elevated peak pressure but the plateau pressure is normal, means that the pathology is in the airway which has led to the increased resistive pressure. This is seen in cases like bronchospasm and mucus plugging. On the other hand, if you have elevated peak pressure but elevated plateau pressure, that means that the pathology is in the lung alveoli or some pathology with the lung compliance, which can be seen in cases like pneumothorax, pulmonary edema, atelectasis, and pneumonia, where the compliance is reduced. So when the compliance is reduced, the plateau pressure increases and therefore the peak pressure increases. Now coming to certain ventilator settings that we go for specifically in cases of ARDS. The first thing, limit the tidal volume, keep the tidal volume low. This is something called the lung protective ventilation or low tidal volume ventilation. So here we are trying to limit the alveolar distension and we give about 4 to 8 milliliter per kg, and we target a plateau pressure of less than 30 centimeters of water. In case of ARDS, we can use a volume limited or a pressure limited AC mode, and many studies have shown that a low tidal volume actually reduces mortality rates in ARDS patients who are ventilated. Next is about PEEP. You have to keep optimal PEEP levels, as I've mentioned. This is to prevent alveolar collapse. So in an optimal PEEP, what happens is that it prevents alveolar collapse and it increases the recruitment of alveoli. Also, this can help keep a lower limit of FiO2, because we know that partial pressure of oxygen depends on FiO2 and PEEP. So if you keep a PEEP at a good optimal level, you can essentially keep FiO2 at a low level, maintaining a good PO2. So if you keep FiO2 at a lower level, you are reducing the risk of oxygen toxicity. Next is something called permissive hypercapnia. So you are actually allowing the PaCO2 to remain more than 45 millimeter of mercury and a low pH of less than 7.35. Why do you do that? This is to allow for a low tidal volume. So here we are allowing a certain amount of alveolar hypoventilation in order to prevent alveolar overdistension if by a high tidal volume. So a permissive hypercapnia is allowed. Now, as I've mentioned, FiO2 at lower limit is to avoid oxygen toxicity. You have to target a partial pressure of oxygen of around 55 to 80 millimeter of mercury, which corresponds to an SpO2 of around 88 to 95%. Now, a few other things that you have to do to optimize therapy in a patient admitted in the ICU for ARDS. As I've mentioned, the plateau pressure. That plateau pressure should be kept less than 30 centimeters of water. So in case the plateau pressure increases to more than 30 centimeters, the management of that is to reduce the tidal volume to around 4 milliliter per kg. And remember, when you reduce tidal volume, you have to increase the respiratory rate in order to maintain minute ventilation. The second, so that's about plateau pressure. The second is to monitor the gas exchange. Gas exchange can be denoted by two things. So one is the pH and one is the PCO2. So if the pH is less than 7.25, this is even below what is permissive, permissive in ARDS. So if the pH is less than 7.25, you would rather increase the respiratory rate rather than increasing the tidal volume, because a low tidal volume ventilation is always preferred in ARDS. And if the pH rises more than 7.5, you can reduce the respiratory rate. Try not to change the tidal volume much. Now, the third aspect that we look at is the driving pressure. Now, driving pressure is formulated by the Plateau pressure minus the PEEP. This PEEP, please note, is what is applied by the ventilator. You can also define driving pressure as tidal volume divided by compliance. This driving pressure has to be kept minimum by reducing the tidal volume or increasing the PEEP. Generally, we reduce the tidal volume. That is the preferred strategy. And in case you are trying to increase PEEP, studies show that you have to the increase in the PEEP should just be kept for around 2 to 6 hours only. So generally we go with the reducing tidal volume strategy. Now, this optimization of therapy is extremely important, and you have to keep assessing the patient with ARDS every 4 hours and monitor all these parameters and of course their clinical response. Certain other measures in ARDS management would include definitely treatment of the underlying cause, negative fluid balance. This is important. You do not want to overload the patient with fluids because that can essentially lead to pulmonary edema. So you have to be very wise in the amount of fluids that you give the patient. So you can have a negative fluid balance by either reducing the fluid intake or by using diuretics. The next important concept is management of dyssynchrony. A dyssynchrony means a mismatch between ventilator-driven breaths and patient's efforts. What this can lead to is it will increase the work of breathing for the patient, it increases discomfort, and it increases the need for sedating the patient, higher amounts of sedation, which is not really good. It can also lead to something called breath stacking or double triggering. Now, what is this? Breath stacking can happen if the second breath is taken very soon after the first breath, so that there is no time to completely exhale that first breath. So this leads to air stacking up in the alveoli. Now this leads to what we call an increase in auto PEEP, an increase in the alveolar pressure because of all that stacked up air. That is called auto PEEP. Now, why would this happen? The reasons this could happen is because the second breath is taken too soon, with less time for the first breath to completely exhale. And that can be because the ventilator is not supplying enough tidal volume in the first breath. So the patient requires more air, so he initiates a second breath too soon. And that is why one way of managing this double triggering or breath stacking is by increasing the tidal volume, so the patient does not need to initiate a second breath too soon. And again, please note, when you increase the tidal volume, you have to maintain it at that low tidal volume ventilation range. So this is in the management of ARDS. Coming to the ventilation or ventilator settings that you use for a patient with COPD. Always note that in COPD patients, we start invasive mechanical ventilation only after a trial of non-invasive positive pressure ventilation like CPAP for 2 hours has failed. Only then you start an invasive mechanical ventilation. So in COPD, what happens? There is increased airway resistance, so more time to exhale air. There is also a ventilation perfusion mismatch. Because of the VQ mismatch, there is increased carbon dioxide retention, and these patients usually have high PCO2 levels. And for settings, what are the settings that we choose for COPD? The first is FiO2. You have to maintain an SpO2 between 93 to 96%. So again, we should not increase FiO2 too much because that could result in exacerbation of hypercapnia. We keep a tidal volume of around 6 to 8 milliliter per kg, respiratory rate of 10 to 16 per minute, PEEP at 5 to 10 millimeter of mercury, and there is something called trigger sensitivity. Trigger sensitivity is the cutoff value of it could be either the airway pressure or it could be a cutoff value of a flow. And once that cutoff value is reached, that is when the ventilator triggers a breath. That is a trigger sensitivity. So if you're using a pressure triggering method, the trigger sensitivity is set at something like -1 to -2 centimeters of water. So this essentially means that the airway pressure should reduce 1 to 2 centimeters below the atmospheric pressure, which is the equilibration pressure. When that pressure is reached, the ventilator triggers a breath. In flow triggers method, the ventilator triggers a breath when the patient generates an airflow of around 2 liters per minute. That is when the ventilator triggers a breath. Now coming to a really important topic called dynamic hyperinflation. Dynamic hyperinflation means stacking of air in the alveoli. It is called dynamic because air accumulates in the alveoli with each breath. So it's a progressive process. In this dynamic hyperinflation, there is increased intrinsic PEEP, which I've already described as auto PEEP. Now, this dynamic hyperinflation could occur because of two factors. One is patient factors like increased airway resistance that makes exhalation of air very difficult, so that the air just keeps stacking with each breath. Or it could be the fault of a ventilator setting. Like if you set the respiratory rate very high, you're giving less time for expiration. Also, if you keep the tidal volume very high, that can also lead to a dynamic hyperinflation. So this dynamic hyperinflation leads to increased auto PEEP, and this auto PEEP can later lead to patient ventilator dyssynchrony. So how can you prevent this dynamic hyperinflation? So the first is reduce the respiratory rate. By reducing the respiratory rate, you are increasing the time taken for expiration, so letting all that air move out. You could reduce the tidal volume. You could increase the inspiratory flow rate so that there is less duration that is spent in inspiration and greater duration spent in expiration. And you can provide extrinsic PEEP. Now this requires some explanation. So when you provide extrinsic positive pressure, what you're doing is you are reducing dyssynchrony. By reducing dyssynchrony, you are reducing the work of breathing and you're reducing the discomfort the patient feels. How? So, for example, suppose we have set the trigger airway pressure that must be attained to trigger a breath as -2 centimeters of water. That is the trigger airway pressure. Alright. So what this means is the airway pressure must be 2 centimeters of water lower than the atmospheric pressure, because atmospheric pressure is what the airway is in equilibrium with. Suppose the COPD patient's auto PEEP, already the intrinsic PEEP is 10 centimeters of water, then the patient has to reduce the pressure first to 0 and then the patient would have to reduce it by a further 2 centimeters of water to reach that -2 centimeters of water pressure. So essentially the patient effort is to reduce airway pressure by 12 centimeters of water in order to trigger a breath, because there's already 10 centimeters auto PEEP. So reduce it by 12 centimeter in order to reach a -2 centimeters to trigger a breath. Now that is quite a bit of work of breathing for the patient. In contrast, same patient with an auto PEEP of 10 centimeters, we are applying an extrinsic PEEP of 5 centimeters of water. What does this mean? So with an extrinsic PEEP of 5, the airway pressure that is needed to trigger breathing will be 2 centimeter of mercury below the equilibrium pressure, which is now 5. 5 is my extrinsic PEEP. 5 is what the airway has to get equilibrated with. So if you want to bring the pressure 2 centimeters below that outside pressure, it should essentially reach 3 centimeters of water to trigger breaths. So what does that mean? This patient would have to reduce his airway pressure by 7 centimeters of water. He has 10 centimeters of auto PEEP. What is required is 2 centimeters below the equilibrating pressure, which is now 5. So essentially it needs to reach 3 centimeters. If the patient needs to reach 3 centimeters, he has to reduce his airway pressure by 7 centimeters only, compared to the 12 centimeters without that extrinsic PEEP. So you can very clearly see how the work of breathing has reduced for the patient. So this is basically how an extrinsic PEEP helps reduce the work of breathing and dyssynchrony in COPD patients. I hope that was clear. Coming to the next topic. So we have talked about the ventilator settings in ARDS, ventilator settings in COPD. Now, how do we wean off the patient off of the ventilator? This is called extubation readiness, and it is associated with something called the readiness testing. Now, before we move on to that, there are a few concepts I would like to mention. So, weaning means it is the process of reducing the support from the ventilator, progressively reducing the support from the ventilator, and making the patient take increasing control of their breaths. That is weaning. What is extubation? Extubation is that physical removal of the ET tube. That is the final step of stopping mechanical ventilation. Now, weaning requires certain criteria to be met before you can wean the patient off of the ventilator. So the pH should be more than 7.25. The partial pressure of oxygen should be more than 60 millimeters of mercury with just minimum ventilator settings. So with even minimal support, the PaO2 should be more than 60. Minimum support means PEEP less than equal to 5 centimeters of water and a fractional inspiration of oxygen of less than 40%. The third is that the patient can initiate inspiratory effort by himself, the patient is mentally alert, and the patient should be hemodynamically stable. If these 4 criteria are met, you can go ahead with something called a spontaneous breathing trial. This means we essentially allow the patient to breathe on their own without any ventilator support for about 1 to 2 hours, and you check the ABG. If the ABG is normal during that time, the patient can be weaned off the ventilator. A second sort of index that we look at is called the Rapid Shallow Breathing Index, or RSBI. That is just the respiratory rate divided by the tidal volume. And if the RSBI is greater than 105, it means you should not wean the patient. Because if the RSBI is too high, it means that the patient is taking very rapid shallow breaths. The respiratory rate is too high and the tidal volume is low. That corresponds to rapid shallow breathing. This means the patient is not ready for extubation. You should not wean the patient off, and he requires continued ventilator support. Also note that prolonged extubation of more than 10 days warrants a tracheostomy. The next and the last topic that I would like to discuss is the role of PEEP in congestive heart failure. PEEP means you are providing positive pressure inside the alveoli, so that corresponds to an increased intrathoracic pressure. An increased intrathoracic pressure reduces venous return, and that will reduce the preload. Increased intrathoracic pressure also increases compression on the pulmonary vessels. This increases the pulmonary artery pressure, and that increases the right ventricular afterload. So that is, keep this in mind. So what happens is that in PEEP, now this is in relation to the right side of the heart. Coming to the left side, when there is increased intrathoracic pressure, there is aortic compression. Because of baroreflex, there is a vagal response and increased parasympathetic output. Increased parasympathetic output reduces mean arterial pressure, that reduces the left ventricular afterload. So this is the effect on the left side of the heart. So combining a reduced preload to the heart and a reduced afterload to the left ventricle essentially reduces the work done by the heart. Also, PEEP reduces pulmonary congestion by reducing the preload, and in effect this is going to be of much benefit in a patient with congestive heart failure. And it has been found, in fact, that PEEP in CHF has a mortality benefit as well. So that is with this video on mechanical ventilation. I hope you enjoyed it. Thank you.